everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about long COVID and how it impacts the brain. There's a lot of people out there who may have gotten COVID maybe a year or more than a year ago and are still really feeling the impact. Usually it's in the brain. Long COVID can create brain fog and other symptoms like fatigue. So we thought we would today delve into the latest research. I'm really happy to have with us William Hu. He's from Rutgers Health, and he's been studying long COVID and not only how it impacts the brain, but how we really should be treating it. So William, thanks so much for joining us and welcome.
Well, thank you for having me, Deborah.
Okay, let's just talk first about what we know about microbes, viruses or bacterias entering the brain. I mean, we obviously know in many people, COVID caused a neurological symptom. What do we know about actually the virus entering the brain and wreaking havoc?
So those are really excellent questions that we don't have complete answers for. So when COVID first hit back in 2020, I jumped into service as well as many of my colleagues, and we started seeing people who had seizures and strokes and other forms of brain diseases that we eventually really just grouped under encephalitis. And at the time, we asked the question, does the SARS-CoV-2 virus enter the brain? And if it did, it was very, very hard to detect using available technology. What we're able to see and what others have reported is that the virus are seen in the blood vessels in the brain, and they likely enter the brain small amounts, and then they may hide out in the brain cells or the inflammatory cells. But just by using conventional techniques like RT-PCR, we have a hard time seeing it. So right now,
what is RT-CPR?
It's RT-PCR. It's the PCR test that we initially used to detect acute COVID infection.
Got it. Yeah.
And that it's not to say it's not there, and that it's just that our available technology cannot confirm it. So
Right. But this is not really surprising given we know the herpes virus, right? I mean, Rudy Tanzi did some work on this we know that the herpes virus can enter the brain and hide out, for a while. So is it much like that? Is that a fair comparison in terms of the way that viruses behave in our brain?
I imagine so. And herpes virus is not the only virus that does that. There's Epstein-Barr virus, cytomegalovirus, and many viruses. And then one of the perhaps scary one is HIV. Even when we cannot detect active HIV in the blood or in the other organs, HIV can hide out in the brain and cause a fairly well-characterized cognitive syndrome. So we've known for some time that these viruses are capable of doing that.
So is it safe to say if you're able to detect in the blood vessels of the brain, then it's in the brain, right? We don't need any more confirmatory studies to understand that. Do we know why some viruses may enter the brain, or is it more that all viruses can, or bacteria can enter across the brain-blood barrier, and maybe it's just how they behave in the brain that causes the impact? Do we know that?
Well, I think that each virus will use different receptors. Each are kind of like the little seats that the viruses ride on to get into a cell. Viruses need to get into our cells to replicate and to survive in a way. So how they get in, very often determine where in the body they will go. So if the brain cells have these receptors, then the viruses are capable of getting in. If the blood vessels wall cells have these receptors, then the virus can get into those cells. And of course, sometimes if there's what we call kind of a broad leakage, you're very sick and you're not getting enough oxygen. Your body is trying to save yourself, and then this sacred barrier between the blood and the brain opens up, then a lot of things can get in. And once you get better, it may be very hard for things to get out.
So what do we know? So, I mean, the symptoms associated with the brain with long COVID we hear the most is, of course, brain fog and also exhaustion. I mean, even people in my own family have this like chronic exhaustion and really, only 1 or 2 hours a day where he feels like he could do something, right? So it's these long periods of exhaustion. So that's obviously related to the brain as well as the brain fog. Do we know like what exactly is happening to give these patients these symptoms?
We don't quite know what causes the symptoms. And I think from a clinical and scientific perspective, it's very hard to draw a line between what we see in the laboratory with what people feel. But then again, we kind of use the association type of test that if we see something, you feel something, we see the thing get better, you get better, then whatever we saw earlier was probably causing or at least related to what you were feeling. So if we're going to use that approach, then I think a lot of what our study showed is that people are feeling these brain fog symptoms because there was a lot of inflammatory change going on in the brain that was detectable in the spinal fluid.
So from your research, okay, so let me just back up a little bit more before we get into what your findings, but long COVID was actually looked at as a possibility for setting off certain things that could lead to Alzheimer's disease, right? So in other words, there's a lot of hypotheses out there. And, I think scientists in a broader sense agree that, there's many different reasons from environmental, genetic, possibly microbes, we need to study them more, that can set a person off on the path. It's not necessarily the main cause, I mean, the main reason, but it is a reason why you would kind of head on that road towards Alzheimer's. Are we not looking at it that way anymore? I mean, obviously, all of this is incredibly new research because COVID hasn't been around for that long. But where do you think, what have we learned in the last 4 years to tell us really, where we are on that spectrum and whether or not is it still possible it could lead to Alzheimer's?
Well, I think there are three ways to answer that question. Number one is, does acute COVID lead to acute Alzheimer's type changes? And there were some early studies in the blood that seemed to suggest that, which led us to really ask the question, can we go deeper? Can we use more accurate markers to see long COVID can be explained in some way by the Alzheimer's marker changes? And the answer is no. I think it was a fairly convincing no, that we no longer believe that COVID, either in an acute form or long COVID form, will lead to sudden Alzheimer's type of changes, even if the symptoms of long COVID and Alzheimer's disease can be similar to outsiders. Number two is, in the long term, does having COVID or long COVID increase your future risk for Alzheimer's disease? That we don't know yet. That is something that we are continuing to follow some people over time who've experienced long COVID, some of whom have gotten better, others have not, to see whether there's a difference in future risk for Alzheimer's disease. And the answer to that question probably won't be apparent for another 5 to 10 years. But then there's a final group of people who are very interesting to us. And they're the people who already have some brain changes of Alzheimer's disease that without COVID, they likely wouldn't have been symptomatic yet. So they will be what's called the asymptomatic or pre-symptomatic Alzheimer's disease stage. But then because of COVID, or even sometimes because of other infections, hospitalizations, their brain disease starts to manifest outwardly. And then so we think that studying this group of people may help us address some of the answers in the meantime as to whether long COVID or COVID causes future increasing Alzheimer's disease risks.
Okay. And what, like, we talked a little bit about inflammation, I mean, and inflammation is still a mystery in terms of the exact role it plays in wreaking havoc in our brains, although there's a strong belief in science that it does play a role. I mean, the pathology of Alzheimer's is beta amyloid, tau, and then inflammation. And I've been told until you reach the inflammatory state, you usually don't see a symptom of Alzheimer's disease. So what role with long COVID do we know that inflammation plays, and how does it manifest?
Well, I think there's inflammation is almost something what we call the triple-edged sword. We used to think it's a double edge. It can help and it can hurt. But over the past 20 years, we really have come to understand the inflammatory proteins, the little proteins that are secreted between inflammatory cells, can actually help neurons, the brain cells, process, survive, and do other activities. So in a way, it seems that our brain at some point in time, thousands or millennia ago, years ago, hijacked the immune system to also serve as other ways to improve our thinking, to speed up our processing. So whenever there is a brain infection or a brain inflammatory event, not only are the cells hurting the neurons, not only are the inflammatory cells hurting the neurons, even these little chemicals that are released can be altering the people's thinking and processing. So that itself may be a side effect or bystander effect of inflammation in the brain that can cause brain fog.
So what exactly are specific research focused on?
I'm sorry, you cut out for 1
Oh,
second.
I'm sorry. I was just asking what specifically, with your latest research with long COVID in the brain, what exactly did you find and what were you focused on?
Yeah, so we were interested in figuring out, number one, whether there's a common signature of inflammation in people experiencing long COVID symptoms. And number two, and I think we were hopeful and wishful at the time, is if we follow these people over time, whether some of the early signatures were associated with whether people got better or whether people remain having symptomatic. So we recruited a fairly sizable group of people, over 300, from the Rutgers Long COVID Recovery Clinic, as well as the community in the New York, New Jersey, Pennsylvania area. And we study how their memory and thinking was, as well as their mood, fatigue, and sleep. Then about over 60 of them underwent brain MRI analysis, and we saw some very interesting things that we would otherwise see almost in a way in herpes encephalitis, as well as other sorts of acute brain infection. But then a small number of them underwent donated their spinal fluid, which is really the only key way for us to examine what's happening in the brain at the moment. And then what we were able to find is that there were a lot of inflammatory changes going on. So number one, we were able to confirm this was not just depression or anxiety of lack of sleep, and it was a fairly organized type of immune reaction. And then the second, when we compare this group of people to another group with Alzheimer's disease, even though we know they don't have Alzheimer's disease, we still wanted to see if the inflammatory features are the same. And then we found that the people with long COVID had very different type of inflammatory changes from those seeing Alzheimer's disease. So in a way, very little of what we've learned in Alzheimer's disease can be directly applied to long COVID.
Okay, so interesting. So when you are finding markers, inflammatory markers in the cerebral spinal fluid. So, you're giving people a spinal tap, basically taking out some of that fluid, looking under the microscope and understanding and looking for biomarkers, specific biomarkers for long COVID. What you found is inflammatory markers, basically, that indicates there is inflammation going on in the brain, right? So would this be is the feeling that because your body is still fighting long COVID, like so making it's actually your immune system that's saying, wake up, we got to fight this. And it's kind of been fighting it for a very long time. I mean, some people have had these symptoms for, a year or two. So is that just because your immune system is overstimulated and activated to fight the virus, and that's causing the symptoms?
Well, there were actually multiple patterns of inflammatory activation. And then so we've been measuring proteins alone in the spinal fluid for over 15 years, but a new technology did not become available until very recently. And I think this is actually one of the largest studies using this technology in the spinal fluid. So we're able to track down the individual immune cells in the spinal fluid, which are essentially the cousins of the immune cells in the brain, and study all the RNAs in these immune cells, such that we know what each line of cell is doing. So what we're able to see is that there's a lot of interferon-driven responses, and as well as other types of responses. When we compared these responses to an unbiased library of other experiments scientists have done, the closest thing that our patterning long COVID looked like was multiple models of acute COVID infection in the cell, in people, in postmortem brain tissue. So in multiple ways, what this told us is that on average 9 months to a year after the initial COVID infection, their body is still behaving as if they have active COVID infection.
That's really interesting. We have a question coming in. GJ is asking, what does research say about lingering anosmia and long-term consequences from COVID? So the loss of smells, when a lot of people have lost their sense of smell and taste. Some of them have, it's a longer term impact. So where does the research come in for that symptom, the loss of smell?
Yeah, we haven't looked at loss of smell, but then in our population, there are a lot of people with persistent anosmia or loss of smell. And then the thought is that when the virus initially gets into the brain, it can potentially go through the nose. And then the first brain cells that the viruses encounter will be the olfactory neurons, the brain cells that are responsible for smelling. So they're the first line of defense, but are also the most vulnerable. And I imagine that the mechanism is that these brain cells got sick and they were injured, and until they can somehow recuperate over time, that the sense of smell will not 100% return. And even in many of our participants, they say that their smell has improved, but then the smell is not what it used to be.
Right.
So it's very much like a brain injury in the smell neurons.
Okay, so in the cerebrospinal fluid, there are inflammatory markers. How do you treat this? And, what's the next step? A lot of people out there are thinking, well, what do I do? Like, is there anything I can take? Are there medications that will help these symptoms?
Yeah, I think that's a great question. And a lot of times the scientists are very good at observing a problem. We're not very good at solving the problem. And so once we found the evidence that, the spinal fluid tells us is as if there's still virus going on, and then we started to look to see whether better prognosis over time or better recovery is associated with a particular subtype. And what we're able to find in people who subsequently recovered is that they mounted a very effective interferon response. Whereas the people who didn't recover, they're in a way still struggling to get their interferons in line to fight the infection. So if following that, what we propose is that some sort of antiviral therapy should really be considered a bit, whether to suppress the virus by itself or use or kind of enhance the body's natural antiviral processes through interferon to clear the virus. Many people have heard about a Paxlovid trial, and in long COVID, it does not seem to have helped. So I think that that is probably not going to be the solution. In China, there's some scientists are using HIV medications, and again along the antiviral therapy approach, and we're waiting to hear the findings. But then finally, because we learn about interferon's role in the long COVID prognosis, there are many forms of interferon alpha, interferon gamma, interferon lambda, that are already being tested in multiple groups of diseases other than COVID. And interferon gamma itself has actually, interferon lambda itself has been found to be effective in acute COVID. Really, I believe a clinical trial using these interferons is the next logical step.
Okay, so would you think, do you have to take these antivirals right first when you get infected, or could this possibly work on people who have had long COVID? I mean, I'm thinking of like the herpes virus, and I think, or any other virus you're treating with antivirals. I remember Tamiflu, right? For example, you have to take it early. You have to take it when you're first coming down with symptoms, to shorten the amount of time duration of the illness. So how would this work in terms of people who've had long COVID for, a year or more?
Well, if we think of long COVID as a form of viral persistence or chronic infection, there's no reason to believe that these antivirals will not work in long COVID. Again, your body has done something to improve certain aspects of the symptoms. It just has not completely cleared the virus. And so it may be that remaining 10%, 20% that is causing havoc. And then so what we need to do is help the body clear that last 10 to 20% so that you're completely free of the viral infection.
So, and as a follow-up, as another question is being asked, is there any evidence about how multiple infections play out for viral persistence, drawing from other viruses, if necessary? Might multiple strains remain or compete, or something else? So yeah, what do we know about interaction with other illnesses and also the persistence of the virus?
Yeah, those are questions we ask ourselves every day almost. And then so they're for COVID, it's been very challenging to understand the impact of multiple infections because of the lack of testing and because of the lack of specificity regarding the strain. Most what we can do is guess the strain according to when somebody got sick, but we don't have confirmation of exactly what strain it was. And so there's a little bit of leap of faith there to better understand it. At some point in time, people thought that, well, if clearing the infection is key, maybe when you have another dose of SARS-CoV-2, your body can jump into action and clear the virus. That has not turned out to be the case. And it seems that if your immune system is not able to do the first time, it doesn't seem able to do the second time. And then so for people who have long COVID, I think the key thing is to avoid getting COVID again. And that's we tell all our patients and research participants.
Is there a particular strain where more people tended to get long COVID from your research? Was there, was it Delta? I mean, we've been through so many now,
Yeah.
mutations. So is there one, were the earlier versions wreaking more havoc than the later versions because now more people have had it multiple times, or what's happening there?
Well, our study focused primarily on people with the initial rounds of the infection, just because where we were and then when we started the study. So I think all we can say is the very early strains. I don't say the earliest because we did involve some Omicron, some Delta people later in the study. And there's some study out there that seem to suggest the long COVID prevalence may have decreased over time. But based on 2023 data still being released by the CDC when cases are being counted, it didn't seem that there was much of a change from 2020 to 2023. So 2024 may be a different story, but we're going to need to start tracking the cases better to even understand.
And interestingly, and this is my very unscientific observation, it doesn't seem like I've heard of any children getting long COVID. Have you?
A large study just came out and it was published in the Journal American Medical Association that children do get long COVID and they get long symptoms. Whether the duration of symptoms, the severity of symptoms are the same or similar to adults, it's hard to say. One thing that was interesting we found was that whereas based on prior knowledge, we would assume people in their 20s and 30s, as well people over the age of 70 to be most vulnerable to long COVID. It turned out that the people in their 40s and 50s were most vulnerable to long COVID. I imagine that has something to do with the aging of the inflammatory system inside the body. And this is a process we call inflammaging. And that seems to be kind of a key area where some of the immune cells start to not function properly. And then so whether children with more immature immune systems do better or worse, we don't know. I think a lot more detailed studies will need to be done beyond just chart reviews.
Yeah, it's interesting too, because I mean, like normally the way that the virus, if you look at the history of the virus, kids didn't get, I mean, certain kids with predisposition or comorbidities would get quite sick, but in general, the way that the virus performed, most kids weren't very sick at all. So it would be interesting to look at the longer term impact and whether or not that's related to other comorbidities, and or the maturity of the immune system. Maybe kids' immune systems are being developed, they're very responsive, I don't know, I'm just thinking off the top of my head, but it is interesting to see the different age groups and how, because certainly there was a huge difference between a 10-year-old getting COVID and an 80-year-old, right? In terms of that the virus performed.
Well, and on top of that, I think it's important to mention that when we study this phenomenon, both the biochemical as well as some of the clinical assessments in people experiencing symptoms and not experiencing symptoms, a number of people who recover from COVID not reporting symptoms also have the signature of long COVID. So why do they not experience the symptoms and what happens to them in the long run? Those are all very important research questions.
Yeah, it's interesting too. I mean, I've surprisingly have never tested positive for COVID despite multiple family members having it. So it's interesting to understand why, like, members of my own close-knit family, some of them have had it 3 times, and yet, what is it there within our own immunity that actually prevents you from developing symptoms? And maybe that will unlock, I'm saying maybe I should
Well, I think all these lines of research will lead to something important. And then I think one thing that we cannot do is just put all our eggs in the same basket.
Yeah.
I'm a fan of interferon. I think we need to conduct interferon trials. But then again, I encourage other ways to improve brain function and to clear the virus.
Okay, so we're getting a few more questions I want to get to. One is, have you noticed any relationship between COVID and blood clots in the brain or elsewhere? Is there a relationship?
I think that's an interesting question based on the recent publication, as well as a number of studies over the years that say that COVID increases the clotting potential of blood. And this is probably not surprising because any infection increases the clotting potential of blood. And this is something that's common in the hospital. This is something that's common in people with chronic diseases like TB and HIV. So it's not really surprising.
Is that
And
because you're getting less exercise or not moving around as much, or why? What is the reason behind that?
no, it's our bodies don't have these entirely independent units. The immune cells are made in the same place where the clotting cells are made. The same proteins interact with each other, and then our bodies are not, perfectly designed for one thing or another. And so even when people have cancer, they're more likely to clot. And so the body's clotting is in a way and sometimes an acute response to something not going well.
So in the study that you just did, you were able have we tested? I mean, obviously, a lot of people have taken Paxlovid right now. So do we know the impact on the antivirals yet with long COVID? Do we have those answers yet?
Well, we don't have any other antiviral other than Paxlovid that's being readily
You're saying the
available,
interferon should be
tested.
introduced
Right,
because
right.
that's
And
a different type of it's a different type of
yeah,
medication.
interferons are the body's natural antivirals, and the synthetic forms which you give to people with the matching diseases are basically to enhance that process. So for a long time, hepatitis was mainly treated with interferon.
So how do you
Um,
make interferons? Do you extract your own? Like, how does that work? Is it a
no,
medication? What is it?
No, it is a medication. It is an injection that people with multiple sclerosis, people with some form of chronic cancers have been getting and tolerating very well for many years. The early forms of interferon were poorly tolerable. They kind of cause they cause symptoms as if you're having severe flu. But now that they package the interferons at the molecular level better, so that they're better tolerated by people.
So, and are those regular shots you have to get usually? Like, what does that look like from the patient's perspective? Obviously applied to another disease because we don't have them yet for COVID. Is that right?
Yeah. Well, so in the only clinical trial, it was a single shot in the acute COVID, and that seemed to have shortened the disease duration for the acute symptoms. And from the long COVID perspective, we have to think about, how long should we give to see sufficient improvement to know whether it works or not. If I were to venture, I would say that we need to at least give it for 6 months, either once a month or twice a month, to see whether people improve over time.
And these, just to be clear, these are medications that already exist, right? They don't have to be invented. So it's like
No,
purposing.
that, that's correct. They're already available. They are already approved by the FDA. The interferon lambda that I mentioned is not yet approved by the FDA, but all the other forms of interferon are. So some of these can be tried once we organize and design a sufficiently powered study.
Okay, and the final question is there one myth, I like this question, you most wish you could dispel? But I'm going to add to that and ask you, from all of the patients in the study, is there one thing that stood out, and were there any ways that people could manage these symptoms on their own, where they were seeing, some sort of improvement?
I think there's so many myths that it's hard to pick one, and I think I may have to settle on two. One is something that many of us hear is just depression, it's just anxiety. We know it's not, both from a molecular perspective, but also from a statistical perspective when we study the symptoms each person has. And I think the other one is very similar from what many people with myalgic encephalomyalgia have experienced, which is the rehabilitation or therapies will get you out of long COVID. Very often, it actually makes symptoms worse, and then so we don't tell people with chronic HIV or chronic hepatitis to go to rehab to get rid of the viruses. So why do we tell people with long COVID to do that? I think those are important questions the medical community, the medical establishment will have to answer.
So is there, I mean, I have a family member who was trying, the hyperbaric oxygen, things like that. Like, is there anything that you found people are doing successfully to just alleviate the symptoms? Maybe not treating in the long term, but just to alleviate some of those symptoms.
Well, I think the only thing that we found effective is pacing. And again, this is something that we borrow from the folks living with chronic fatigue syndrome, which is that you have to reduce the amount what you expect to do on a daily basis so that you give your body a chance to recover in the long run. And then often it is a struggle because some people will feel better one day and they feel they can do more, but then that they end up very often paying a price the day after or even 3 days after. And so I think if we're able, for people living with long COVID, they're able to reduce their amount of activity, and then we often aim for something in the 60 to 80% range. You know what you can do, but you know what your body can handle, and lower that a little bit, and then see how today goes.
So is chronic fatigue really the main big symptom that lasts for a very long time, or is it the brain fog, or is it both, or?
Well, it's really both, and they both come hand in hand. And the other symptoms that we haven't talked about include headaches and lightheadedness, which is not always, at least clinically, associated with POTS and are difficult to explain. But they tend to go hand in hand. And when they get better, they all get better. Or when they don't get better, none of them really improves.
Okay, well, I've gone way over my time because I find this topic really interesting and I know it impacts a lot of people. And I think also what we learn from what viruses do, the more we learn about what viruses do inside the brain, the more we're going to learn about other, areas that impact the brain. So, William Hu, thank you so much for joining us and for your research. And please do keep us abreast of any new discoveries because I know it's interesting to a lot of people and relevant.
Well, thank you for having me.
So if you missed any of this interview or want to know more, don't forget to go to beingpatient.com. We post all these interviews there so you can watch them in their entirety. Also, sign up for our newsletters on beingpatient.com because that's when you'll hear about talks like these. So thanks everyone for watching, and we'll see you next time.